Hello, my name is Suzanne Reardon, and we will be talking about community-acquired pneumonia. Community-acquired pneumonia is any pneumonia infection acquired outside of a hospital in a community setting. It is the 8th leading cause of death in the United States. It significantly impacts the healthcare system. Over 5 million people become ill every year, and over 1 million people are admitted to the hospital annually, and 90,000 deaths occur from pneumonia. This significantly impacts the elderly and those who are compromised with chronic respiratory diseases and chronic diseases. Thus, it is crucial to recognize and treat swiftly to promote positive patient outcomes. Pneumonia is an infection of the lung parenchyma. Pathogens infect the lower respiratory tract and promote an inflammatory response from the host. This causes an infection in the alveoli, leading to pus in the small airway spaces, which leads to inability of gas exchange and proper function due to the infection and inflammatory response. Pneumonia is spread through aerosolization, aspiration, spread from another infected site, and direct contact with an infected site. Aerosolization, such as coughing and sneezing, is the most common avenue of infection. Risk factors include the very young and the very old, younger than 2, and 65 years and older, history of respiratory infections, alcohol abuse, smoking. Cigarette smoking damages the protective cilia in the lungs, which decreases the body's immune response. Patients who are immunocompromised, as well as people who have chronic diseases such as COPD, cardiovascular disease, diabetes, heart failure, and renal disease. Pathogens that cause pneumonia include bacterial, viral, and fungal pathogens. The most common bacteria pathogen to cause pneumonia includes Streptococcus. Viral pathogens include influenza virus and COVID-19 virus. Bacterial pneumonia is more common, severe, and more likely to cause hospitalization. And fungal pathogens are least likely to cause pneumonia, and oftentimes those that are affected by the fungal pathogens include those that are immunocompromised, such as patients with HIV or organ transplant recipients. Common symptoms can include chills, difficulty breathing, shortness of breath, fatigue, pleuritic chest pain, and myalgia. Physical findings during the examination include crackles, tachypnea, dullness on percussion, Common signs that you will see include fever, decreased breath sounds, and productive cough that is a rust-colored sputum. Typically, patients with pneumonia will present acutely ill with chest pain and splinting, leaning to the side with the chest pain, crackles, and dullness to percussion which is from the overabundance of fluid in the alveoli. Classic signs of consolidation include the following: echophony, which is amplified echo voice sound on auscultation, and bronchophony, which is amplified volume of patient's speech through the lung fields. Differential diagnoses include acute bronchitis, bronchiolitis, asthma, croup, heart failure, influenza, SARS-CoV, as well as COVID-19, SARS-CoV-2, pneumonitis, tuberculosis, and bronchiogenic carcinoma. Laboratory and diagnostic testing. There are 3 areas to focus. Laboratory and diagnostic testing. There are 3 areas to focus on for proper diagnosis, which include chest x-ray, leukocyte count, and gram stain of sputum. The PA and lateral chest x-ray will show classic signs of patchy infiltrates, which you can see on this radiology study to the right, as well as dense homogeneous shadows in at least one lobe. Those are both classic signs. Findings in the chest x-ray can assist with recognizing if the pathogen is bacterial or viral due to the presentation, the characteristic, and the location on the radiology result. Lobular infiltrates are a strong correlation of bacterial infection and are noted as dense homogeneous shadows involving one or more lobe. A viral infection can be recognized by diffuse interstitial infiltrates. Noting lesions or cavities in the radiology test results are helpful in distinguishing differential diagnosis and further investigation down a different path. Pulse oximetry with hypoxia, the CPC with diff, and leukocyte count shift to the left. Gram stain and sputum specimen is diagnostic to the bacteria or pathogen. Influenza testing and COVID-19 testing to rule out virals, and blood cultures, which are recommended with severe disease to look for bacteremia, which is a severe infection in the blood. Patient's plan of care is going to either be outpatient treatment or hospitalization. Considering outpatient treatment would include the patient to not have any comorbidities, stable vital signs, awake, alert, and oriented, no mental status changes, and can safely treat outpatient. Patients to consider for hospitalization are those that have alterations, often have comorbidities, and a screening tool to use to consider the severity of pneumonia include the CURB 65 severity screening. Numerical scores are given for confusion, BUN greater than 50, respiratory rate greater than 30, a systolic reading of less than 90 and a diastolic blood pressure reading less than 60, as well as age greater than 65. Taking those into account and coming up with a numeric value to consider the severity of the patient's symptoms to guide care of sending the patient to the hospital or treating outpatient. When treating for pneumonia, there are treatment standard guidelines to utilize with the most up-to-date and current research and education. Patients with no comorbidities or risk factors for MRSA or Pseudomonas can be treated with monotherapy with amoxicillin, doxycycline, or macrolide antibiotic. Patients with comorbidities, chronic diseases such as diabetes, cardiovascular disease, COPD, and alcoholism. The recommended guidelines include combination therapy with amoxicillin, clavinate, or cephalosporin, and macrolide or doxycycline, or monotherapy with respiratory fluorochloroquine. Non-pharmacological interventions include increased hydration, 3 liters per 24 hours, resting during acute phase, treating symptoms, utilizing humidified air for comfort, and specific guidelines of when, or instructions as when to seek medical attention or advice. Pharmacological interventions include analgesics for pain, antipyretic for fever, cough, expectorant to help loosen secretions and remove, and antibiotic treatment according to guidelines, 5 to 7 days, either PO or IV, depending on where the patient is and the severity of the illness. This is my first reference page. Second reference page. And I thank you for your time.